My name is Xavier Montalban. I am a neurologist. I work in Barcelona. I would like to thank very much organizers, Professor Giancarlo Comi and Pierre Beneke for inviting me, and also thanks very much Unrecognized, Patrick and Paula job in putting together all this agenda, which is not always very easy. I think I should ask some of you to come to the table or to the armchairs. May I ask Angela White? I will introduce these people later on to come here. Thank you, Angela. May I ask Valerie Block Valerie to have a seat in the armchair in this case. Paul Kamudoni, also. Paul, where are you? Right, going to the armchair as well. Helga is with me already. Thank you. And then Professor Soelberg, Sørensen, to come to the table. So, thank you. I think the title of this section is really very attractive. SAD is role of PROMs and patient-generated data in unmasking unrecognized progression. So we are now in, it's a very timely topic. Progression is our black hole. There are a number of global initiatives, especially the Progressive MS Alliance going on, but also PIRA and is really very, it's a hot topic. PIRA is now discussed in every single scientific meeting. There's a number of papers during the last year, a couple of years on PIRA. And the question is, okay, how can we identify progression? Is just measuring EDSS every 6 months in our outpatient clinic, or there are other tools? And I think we will be discussing this among other topics as well. So now I would like to introduce properly Angela White, who is an active ECT member, is the engagement coordination team. She has been involved in the packet 2 activities. And she is a patient advocate and volunteer of the National MS Society, and she will be talking for 5 minutes on PROMs and the clinical consultation and personal perspective. Angela?
Thank you so much. So the reality of MS in life is that each day presents a clean slate. One may awaken with no changes in one's situation, circumstances, or abilities since one went to sleep, or one may awaken with everything changed drastically. In truth, this may be true of every human being, but it is an inescapable cloud hovering above the heads of those living with or affected by MS. The uncertainty, the physical changes, the cognitive changes, the emotional changes. Given this daily unpredictability, and this is at a minimum, sometimes it's hourly or shorter duration, it can be overwhelming to catalog one's state of being in the intervening weeks or months since one has had a neurological visit last. Barring a relapse or the emergence of a new, unusual, or worsening symptom, it can be difficult to capture trends in one's journey with MS, to make associations between external factors that may be causing changes to one's journey versus internal factors, signaling changes in MS. And while true for those with relapsing remitting MS, this is even more challenging and critical for those with progressive forms of MS. Thus, one's visit with a neurologist, which may last as little as 15 minutes, becomes a game of whack-a-mole. And I understand from my colleagues, not everybody understands that terminology, but that's okay, because it's tracking, targeting, and trying to hit whatever symptom is presenting at that time, if any. Even if there are no objective measures by which presenting issues may be assessed, and too few tools with which to assess them. The once or twice annual assessment then devolves into a discussion of how one is managing on one's DMT, DMD, the standard course of neurological clinical tests, and perhaps a review of one's last MRI. This snapshot in time, conducted in a closed examination room with no external stimuli, often generates conclusions that one is stable, that there are no clinical complementary or rehabilitative interventions needed. Yet, an in-clinic assessment, devoid of the vagaries of daily life, does not provide a meaningful course of action for one living with MS. On a particularly asymptomatic day, one may receive no options for addressing symptoms and the impact they have on quality of life. On a particularly symptomatic day, one may receive orders for a course of steroids and a battery of tests, but still no options for addressing those symptoms and their impact on quality of life outside of acute manifestation. Thus, not only does one continue to have a particularly symptomatic day, but one also must endure additional tests, procedures, and medications, costing time, money, and physical, mental, and emotional energy, all of which are generally tenuous for one with MS. Consider, too, the impact on health system, resources, personnel, and finances. I wear a fitness device daily. Ostensibly, it can capture motions and determine in which activity I am engaged. If there were a device that could be calibrated to detect loss of balance, incoordination, tremor, and other symptoms, not only could this be useful for one living with MS, but changes in measurements over time may prove to be predictive of relapse or progression outside of inflammatory responses on MRI, and too subtle changes to be assessed using subjective in-clinic examination methods. Were one's healthcare team to have access to the objective raw data collected over time, particularly measures that were outside of one's personal individualized range of normal, that could trigger inquiry into what factors were contributing to the variance and provide more useful methods by which one may be treated. As it stands currently, individual cases of MS are treated using broad criteria applicable to the average or most common case, but that only assesses an individual against others, not against themselves, which obscures or misses completely any progression or worsening based upon that individual's unique calibration of normal. Patient-reported outcomes that could be incorporated into wearable devices could offer this information, encourage conversations of substance, and provide insights into what one does or what one does not do to make meaningful difference in one's overall health, MS, and its symptoms, as well as one's quality of life. This could change the field of clinical care for the better. Finally, with the additional information captured from even a fraction of the more than 2 million individuals living with MS globally, we might gain more data for use in clinical or research trials, understand more about MS, and learn factors that turn on or turn off autoimmune responses, interrupting the course of the disease, and maybe even reversing or restoring lost functionality. Lofty goals, yes, but those of us living with MS have high hopes. If a non-invasive, personalized way of assessing our condition over time, not just in a 15-minute biannual appointment, were available and used by healthcare teams, particularly outside of MS clinics and MS specialists, those places where the majority of those living with MS receive their care, to enhance daily quality of life, and with approval and reimbursement from payers, there is no burden too onerous to prevent us, those people living with MS, from using and engaging with it. Thank you.
Thank you very much, Angela, for the nice speech. Thank you. We'll have time for questions later on. It's now my pleasure to introduce Professor Valerie Block. She is an assistant professor at the UCSF. She has a joint appointment in the Departments of Physical Therapy and Rehabilitation together with the Department of Neurology. And the title of your speech is Recognizing Progression in MS, Delivering on the Promise. You have 20 minutes for that. Thank you, Valerie, for being here.
Thank you. Thank you. I am not sure how to...
You click forwards and back.
Okay.
This is the point.
Great. For someone that's supposed to be good in technology, that was not a good start. Mm-hmm. Thank you, Professor Montalban. I also want to thank the organizers for inviting me today, and I'm really excited to be part of this really important discussion. Here are my disclosures. So, although most of you are familiar with this, I just wanted to put this up, and I'd be remiss because there have been some evolution in the definitions over the years. So I just wanted to highlight the differences between patient-reported outcomes and then both the active and passive forms of patient-reported outcome measures, or PROMs. So asking what is progression isn't really that easy an answer, so it depends on who we ask. In clinical trials, they're the stringent endpoints that need to be reached, and for clinicians, it takes on maybe a broader definition. And then for patients, it can really be the sustained increase in the effect of any number of symptoms, and also a vivid worry about the future. And as was mentioned earlier, there are different ways to describe worsening that's insidious, or maybe we can call it ignored, or maybe it's just confusing or hard to measure. And there's been considerable discourse over the last few conferences and presentations earlier this year that have all centered around the nomenclature. There's the elegantly described silent progression, there's PIRA, or the progression independent of relapse activity, and of course, unrecognized progression. But all of these have the underlying message that there is so much of this maybe insidious worsening in MS that can often occur really early on in the disease that we're not able to detect with a lot of the mainstream outcomes that are used to date. And don't get me wrong, we've come such an incredibly long way in MS, I think only second to AIDS research. But my husband the other day put this image in my head, and it really resonated with me because so many of the tools that we use for clinical trials to find novel and exciting MS interventions and treatments are actually the same ones that were state-of-the-art decades ago, even though we know that they have so many recognized limitations. And of course, as was mentioned by Angela, the EDSS is one of those. It's one of the most common, if not the most common, primary endpoint for clinical trials. And not least of one of its weaknesses is that it is just a snapshot of function, usually in the artificial clinical setting and usually once, maybe twice a year. It's also very heavily weighted on ambulation. And with this, we miss so much of that granular differences within each disability level. So, for instance, someone with an EDSS of 6, we know that that person needs a cane to walk. But it doesn't tell us whether that person is really active with their cane, whether they participate in their community, in their society, or whether that need for their cane basically renders them homebound. Then there are other established measures like the MSFC, the various versions of NEDA, I think we're up 3 to 6. These all have advantages, but they also have real limitations, which I think will be discussed later on this afternoon. And then we have quantitative imaging, which elegantly correlates with disability progression. And yet, the latest cutting-edge spinal cord MRIs, which have shown great promise, are not universally or globally available yet. And then, of course, we have patient-generated data, consisting of these 3 main spheres. including active and passively collected information on MS functional domains. And later on this afternoon, I know that we're going to hear from the various leaders and members of the PROMs working groups highlighting the many different angles that this initiative is taking to engage all the stakeholders. But for this talk, I'm going to focus more on digital tools and passive monitoring. Now, because of the acknowledged limitations of the traditional measures, there's growing consensus for the value of these patient-generated data, PROMs and PROs, both in clinical trials and in care. And this recognition for the need to enhance our traditional measures with data to quantify the patient experience. But as we know, there are still many challenges from using PROMs to clinical trials to care. We need buy-in from all the stakeholders, so the regulatory agencies, the FDA, EMA, the industry and pharmaceutical partners, the clinicians that are going to be administering these outcomes, the insurance agencies, particularly in the United States, the scientists that are going to be interpreting this data, and then, of course, central to all of this is the patient. So I want to give one specific example, and this is the MSFC. So we know that bladder function is a relevant and really important part of quality of life, overall wellness, and progression in MS. However, it was specifically excluded from the MSFC because there was no reliable, objective, and consistently collected outcome measure that was used in the clinic setting or outside of the clinic setting. Another example that's in this similar vein is the EDSS. So a transition from a 1.5 to a 2 isn't considered clinically meaningful in a trial or even really clinical care. It's just a blip. But this can mean daily use of diapers or nappies for patients, which really results in a catastrophic change in quality of life for the person. So as I mentioned previously, the primary endpoints for clinical trials right now are mostly snapshots of function, and this maintains a really high bar to overcome, particularly for short proof of concept, maybe phase 1 trials. It means that this new novel treatment in a relatively short time has to result in a transition, for instance, from using a cane in EDSS 6 to not using a cane in EDSS 5.5, and it doesn't go deep and look at any other changes that could be occurring. Now, this is starting to change, albeit slowly, and the FDA have recognized the importance of PROs, such as the NIH Promise Bank, for assessing efficacy outcomes in MS. And for passive PROMs, in the SPY2 study, the regulatory agencies were interested but not yet fully invested, and it was allowed, using Fitbits was allowed as an exploratory outcome measure. So to highlight some of the ways in which we can and have been integrating PROMs, I want to give some real concrete examples from a spectrum of functional disabilities, from overt to subtle to maybe a bit more hidden. And the first example I want to highlight is ambulation. As most of us know, ambulatory impairment and gait dysfunction are some of the most maybe common, visible, and prominent symptoms of MS. And accelerometry and activity monitoring is probably one of the most established of the passive monitoring outcomes, with growing research and widespread application. So this is one that's easy to measure, it's easy to obtain, it has inherent validity, and I'm also fairly confident that it will we'll see this in various forms being used more and more. So our experience with remote wearables has taught us a few lessons, and I'm going to go through these over the next couple of slides. So in the FitTrim study, we enrolled 100 people with MS and asked them to wear a Fitbit for a full year. And over the first month, and I think you can see the pointer, over the first month, the average daily step count over the 30 days here, and then the EDSS grouped into low disability, moderate, and then higher disability, on the x-axis. And what you can see is that with higher disability, you have lower step count. And this is what you'd expect. But what's notable here is the wide variability around each EDSS score. And, as an example, the EDSS 6. So these were people that were all designated in EDSS 6, and over the first month, so on average over 30 days, some of them were doing over 7,000 steps a day, and some of them were only doing 1,000 steps a day. Now clearly this isn't the same disability level, and yet they were all designated as an EDSS of 6. So we also learned that, well, remote monitoring was feasible over a year. We had a retention rate of over 82%. And here we looked at change over the year. On the y-axis, you've got the average daily step count. On the x-axis, you have weeks over the year. And we grouped participants based on their EDSS change from baseline to the year EDSS. And those who improved, which you can see in green, had a trend in step count increase. Those who remained stable, in blue there, had no significant change in steps. And those whose EDSS worsened, you can see there was a significant decrease in step count. In fact, those who started the study with a low step count, so below 4,700 steps, had a 4 times greater odds of worsening at the year. Now, because this was a highly managed, highly treated cohort at UCSF, the majority of our patients were in that blue, stable EDSS group. So we decided to tease out the different disability groups. And another lesson that we learned is that we were able to capture some of the progressive worsening or improvement in function. So in this graph, although everyone had the same EDSS at baseline in a year, their EDSS was stable, all of these participants, you can see that some of these groups had a significant change in steps that wasn't detected by the clinical measure. And then also in the FITRIM study, we did falls questionnaires every 3 months. And falls is a notoriously difficult symptom to objectively measure, or act to difficult measure. In fact, the current literature suggests that just asking someone if they've fallen recently is more predictive of a future fall than some of the more complex measures that are out there. And so we used average step count, so PROMs and PROs, the MS-WS12, which asks about how much the person thinks that MS has affected their walking over the past 4 weeks. And we showed, you can see that there was lower average daily step count in those who reported a fall, and there was significantly higher or worse scores on the MS-WS12 in people who reported a fall compared to those who didn't. And when we used stepwise regression, we showed that the MS-WS12 was a major predictor of future falls in the year. Remember, we asked them every 3 months in this study. And the SPY2 study, which I mentioned earlier, was probably the first phase 3 international placebo-controlled study to incorporate remote activity monitoring as an exploratory outcome measure. And for those of you who are not familiar with this study, it was done to evaluate the efficacy and safety of high-dose biotin, MD1003, in patients with not active progressive MS. And although sadly this was a negative trial, we did see that there was a decrease in steps in those with worse EDSS and worse times on their 25-foot walk. So this was similar to our FITRIMS trial. And that translation from our single-center study leveraged into this really large randomized control trial was really exciting. In fact, operationally, that we were able to measure remote activity monitoring in this international multi-center, multi-language randomized trial in over 600 people with progressive MS was a really important milestone. So I just want to go back and talk about one patient, although we had many like this, in FITRIMS. And their EDSS was stable over the year, their time 25-foot walk was stable over the year, and yet his average daily step count really went down. And when we looked at the other PROs and when we were speaking with him, his urinary incontinence was the driving factor in this decrease in physical activity and participation. He no longer felt like he could leave his home for any amount of time, and this always makes me emotional. He didn't go to his daughter's wedding because he was scared of embarrassing her or having a leak. So we know that bladder dysfunction is a huge symptom. It affects over 80% of people with MS over the course of the disease, and yet it's often really under-ascertained. And as we saw with its exclusion from the MSFC, the current outcome measures are just not really there yet. So for this domain, which is not as tangible or easy to sort of get our heads around as ambulatory monitoring, we need to be a little more creative. So in a pilot study funded by the National MS Society, we aimed to look at commercially available neurotechnology tools that we could use to improve evaluation, monitoring, and perhaps even treatment of bladder dysfunction in people with MS. And we started off by using a human-centered design, and we convened a stakeholder group of many different MS experts and people with MS who had varying degrees of bladder dysfunction and tech literacy, which was important. And we asked them to evaluate and assess these commercially available remote bladder devices with the aim of looking at monitoring and treatment of urinary incontinence caused by bladder dysfunction. Now, this stakeholder design is one of the foundations of the PROMs and the working groups, and really key to finding solutions that will be used and that are useful for the intended users, be it patients, clinicians, researchers. Now, from the many devices that we looked at, we ended up with two, and I want to highlight one in particular, the D-Free, which was a small wearable ultrasound device that Bluetooths bladder fullness to a smartphone app. And from our interim analysis, we have seen that we're able to obtain frequent at-home post-void residuals. And a post-void residual, or PVR, is the measure of urine that is left in the bladder after the patient has been asked to completely void. And here you can clearly see that the pre in green versus the post in purple void volumes, you can see the difference between those. We did Bland-Altman plots, which showed no systematic bias between the in-clinic PVRs and the D-free PVRs. And we were also able to obtain objective measures of frequency. Rather than asking someone how many times did you go to the restroom today, this gave objective measures of frequency. And there was a high correlation between the 3-day bladder diary, which asks just that, and the D-free. Now, this is just one device, but to me it's really interesting because it allows us to passively monitor bladder frequently, so get frequent measures, and at home in their ecological environment. And this allows us to capture fluctuations and variability on a much more granular level. And it also maybe has the potential to capture some underlying early progression of this symptom. So the last example is one that's really nebulous and confounded by many others, and of course that's fatigue. And there's no gold standard objective measure for fatigue that I'm aware of. And to date, the patient-reported outcomes are the main way to measure fatigue. And I think, as I mentioned earlier, the FDA have recognized the importance of PROs, such as the NIH PROMIS Item Bank, and I think these and others will be discussed later on this afternoon. So to highlight the fact that PROs are the sort of gold standard at the moment for fatigue, in this randomized, placebo-controlled, double-blind trial led by Dr. Badia Nubayash, the efficacy of 3 medications for fatigue were compared. And the primary endpoint was the Modified Fatigue Index Scale, so PRO. So if indeed we're stuck on PROs for now, for this intangible symptom, then what's next? I think one of the first things is that we need acceptance for this. And we are getting there. So at ECTRIMS, the results of the evobrutinib phase 2 PRO data were presented. and PROs are being used in the phase 3 BTK trials to measure disability accumulation and integration of the patient perspective. But how do we operationalize and actualize PROMs for fatigue and fatigability? So with the widespread use of smartphones, this can allow us for frequent momentary assessments of MS fatigue in real life at home, maybe reducing some of the recall bias that's seen in some of these other traditional measures that are not done as frequently. And then wearable devices might be able to provide insight into some of the fatigability and activity levels corresponding to these, which are often influenced by subjective fatigue severity. So another option is maybe integrating remote fatigue measures and objective fatigability into a composite score might provide a more comprehensive assessment of the overall symptom. And so looking ahead, we need to be sure that all of this great work translates back into action. And one option is a closed-loop care model, where we want to improve lives of people with MS by aiding early detection of changes, prompt intervention, and then sustained changes in improved function. So is our goal to have patients walking around with multiple devices all the time forevermore? No. But is it a good intermediary outcome until, for real world, until we get to the achievements that we need to fully uncover unrecognized progression? Yes. So in summary, our clinic research and measures today are mostly snapshots of function that fail to capture the subtle nuances in progression. And identifying objective measures of functional domains and monitoring MS fluctuation over time will help MS interventions and treatments maybe pass that hurdle from phase 1, phase 2 clinical trials to secure a wider access to care. And with that, I look forward to the presentations and the other discussions this afternoon, which I'm sure will help us redefine the state of the art. Thank you.
So thank you very much, Valerie, the very nice presentation. It's my pleasure now to introduce Dr. Paul Kamudoni. He is a member of the WG2 here in PROMs. He is the scientific director and of patient-centered research at Merck, and the title of your speech is Industry Perspective, and you have 10 minutes. Thank you.
Thank you. So once again, good afternoon, good morning, everyone. I would like to thank the PROMs initiative for the opportunity to sit back and reflect and share some thoughts on what it means if we achieve this goal of using PROs to provide insights on silent progression. So as I say, these are really reflections on the opportunities and some of the challenges, and probably a lot of the thoughts, ideas, and principles shared by the previous presenter will be very useful as I'm going through some of the ideas that I'll present. So my focus is going to be on two particular aspects. So the first part is reflecting on the value and the opportunity related to using PROs as a way of capturing silent progression. And this is really taking a drug development perspective. And then secondly, I will share some thoughts on how industry, or what needs to happen in order for industry to support alignment and standardization of PRO measurement in light of assessing silent progression. So I won't spend much time on the background because the previous presenter really unpacked the concepts of PIRA and progression, which is below clinical observation. But I want to highlight one element, and that is to say the nature of silent progression means that there are a lot of patients who are currently not being treated appropriately. So really, it's an unmet need which we are not able to accurately quantify. So as a drug developer, that's the angle we're looking at this issue from. If I take a step back and think about the phases of drug development, I would say that transforming how we assess progression is going to have an impact on the full journey of a drug, really from bench to clinic. So it would transform how we do our discovery. So this means in the earliest stages of drug development, being able to have PROs that are nicely linked to specific activities and underlying mechanism of action will allow us to have new definitions of targets and tissues that we need to drive in designing our programs. And that's also important for validating some of the biomarkers that are being hypothesized as being indicators of CNS activity. And then once you move on, once we move beyond the first phase of the science, we'll have tools that we can then begin to define the patient populations in ways that we are currently unable to. So this means, in addition to using the standard clinical measures, if we're able to show that certain functional assessments really tie in with certain CNS disease activities, then we should be able to define patient populations for our programs tied to specific domain and scores. And then with clear definition of those patients, we can quantify exactly what our programs would aim to achieve in improving the condition of those patients. So really in the third step, that's when we talk about the clinical programs, like the clinical trials. And I think the greatest opportunities there are around shifting how we're assessing the outcomes. So I think there was a good proposal from Paula on, can we really get PROs to serve as a primary endpoint? I mean, I'm imagining that that would be possible. I think the main thing would be that we're able to improve the sensitivity of outcomes that we use in our programs, which would directly have an impact on how we design the trials, the size of the trials, the duration of the trials. So in essence, it would really transform how we conduct MS trials, but we're really speaking of the future here. And then finally, assuming that we are successful in transforming how we do trials, we would need then to clearly demonstrate what the added value and what the impact of progression is. So really silent progression in terms of things that people with MS experience on a day-to-day basis. So these are aspects that specific healthcare stakeholders, HTA agencies and others are keen to see. And I think getting to that point would be important to tie silent progression to specific things that change in the patient's everyday life. Now I'll move to the part where I'll talk about the specific opportunities we have at working together as industry, but also more broadly. So here I think the question is, how do we move forward in addressing the many open questions around measurement, agreeing specific outcomes, generating evidence? So I've just laid out a few thoughts on all the pieces that would help us to move forward. I think the key message is we need the right incentives across the stakeholders, and we need a strong framework for collaborating. So this means starting with how we think about outcomes measurement and definition of core outcomes and development of scales. This can no longer be a solo effort by specific sponsors to support their programs. This needs to happen in a coordinated fashion. We need to avoid proliferation of new scales, which simply replicate what's already there. And then the second piece is, if we are at ECTRIMS, there were a lot of questions around what needs to happen for us to assess specific hypotheses. All of this is going to require a lot of data. And I think we need to strengthen the existing networks we have for sharing data and performing research that help to test different hypotheses. And then secondly, assuming that we have a strong collaborative framework, then we need to eliminate barriers to use of specific measures or to use measures for different purposes, which means we need to make measures available that are valid, that are responsive, available in multiple languages for assessing all the key outcomes and concepts that are agreed to be relevant for measuring silent progression. I want to touch on other aspects that will be key in this, and I think the previous presenter touched on this a bit. It's very important for the industry when health authorities are involved, because that becomes a strong incentive that this needs to be done. It's not just a nice to have, it's something that's being asked for. So in this case, the engagement of EMA, FDA, and other important health authorities in setting the course, defining guidance, outlining recommendations is going to be key to get industry to commit and to invest resourcing in moving this topic forward. Finally, I want to recognize that initiatives such as the PROMs initiatives are key in defining and supporting the wider adoption of whatever measures are agreed and encouraging their use in clinical practice. And I will say that this is also a strong incentive for industry when a standard has been set that's agreed by the rest of the community to adopt those standards. Now, in closing, I just want to share just two key points. One is that we are at a very unique point in the field where PROs are not just a means to understand what patients or people with MS think is important, but are going to be key in how we understand the disease and ultimately how we develop drugs in the future. So that's an important context to have. And then secondly, we need to strengthen the multi-stakeholder collaborations that we have at the moment, making sure that all stakeholders are fully engaged, which is then going to be key and is going to encourage the industry to commit and to support whatever is the aligned view of the field. Thank you.
Well, thank you very much, Paul, for your talk and for keeping on time. So now it's time to start our roundtable. And I think we have a virtual guest, Dr. Daniel Ontaneda. Are you around? Yes, you are. We can hear you. Not yet. Not yet, Danny. Yes, wait a minute. Can we fix this? Say hello.
Hello.
And now we can hear you. Thank you, Danny. Thank you for staying with us. And also now Professor Per Sørensen will join the roundtable. You know Per very well. He is a professor of neurology and a senior consultant at the University of Copenhagen and has been in the MS world for 5 years, 6 years, something like that. So thank you. So let me just start with one question for Daniel. You have quite a lot of experience at the Cleveland Clinic, Daniel, and you have been using the MS Pass for a while now. So which can be the contributions of patient-reported data to the recognition of disease progression? What is the start of art on patient contributions? Which is your personal experience on that?
Yeah, well, thank you so much, Xavier, and thank you so much to the organizers of the event and also the three, I think, excellent presentations that we just did. And I think they've really given us a framework of how patient-reported outcomes may work. I think from my perspective, I would say that patient-reported outcomes are no doubt important in how we think about the disease and how we think about progression. I think we've talked a lot about how we define progression and also how we might use clinical tools to further refine what we consider progression. And we can see examples of this, specifically when we think about progression independent of relapse activity. When you look at just EDSS progression, if you add on functional measures, that actually increases your ability to demonstrate this progression occurs. And I think it's only natural for us to envision the utilization of patient-reported outcomes to enrich those experiences of patients of the disease that might be worsening in a slow fashion that is akin to what we would document as clinical progression when we see it on the neurological examination. I think, it certainly is not without its challenges. I think there has to be, somewhat of a methodology around how we determine what we call progression or not, similar to what we've done with EDSS and with the multiple sclerosis functional composite. I think one of the key areas that we have to work on is taking patient-reported outcomes and operationalizing those patient-reported outcomes in a way where we can classify somebody as having progression or not. And it gets a little bit around to the topics that Valerie spoke about, which is PROs, of course, will have some measurement noise around them. There will be day-to-day variations. And I think what we really need to do is be able to determine when those changes are, changes that we can confirm as a true progression of disease. So I think that increasing the scope of how we capture and how we think of progression is the first step. 2, I think, is operationalizing it. And 3, thinking about how we can do a lot of these patient-reported outcomes and patient-reported outcome measures from the distance, that is, from the patient's home. One of the challenges we had previously is that we would bring people in and they would all have to do paper PRO forms, or they have to come in and get performance measures done in the clinic. One of the advantages that technology offers us is the ability for patients to conduct these from home with basically computer-generated testing that can also facilitate, make the testing shorter, and also certainly with neuroperformance measures that can be done from the home as well.
Thank you, Daniel. Another question. So, which is the neurologist acceptability in using PROMs? And are you, because I know you are using them, and you told me once that you take those into account in your decision-making process, even for treatment. Is that correct?
Yeah, I think that's correct. I think there are some barriers related to how well neurologists will incorporate some of these measures. That's undeniable. But I think that, we at the Mellon Center use a battery of neuroperformance measures, mainly based on NeuroQual, which was part of the NIH toolbox, which are quality of life measures that are geared towards all types of neurological disease. And I think that we use these day in and day out. Every time I see a patient, one of the things I pull up is what their patient-reported outcomes look like. And it many times is a reflection of, what the patient is telling you in the clinic. And many times it can even be also a reflection of what an MRI is showing or what an exam is showing. And so I think that using these measures tangibly and experimenting with them and talking to patients about them are key. I think one of the bigger challenges is, how to create thresholds for action based on these measures. That's where it's, I think, a little bit harder. And, we certainly have to differentiate, what's a minimal detectable change versus a, minimal clinically important difference. All those are measured for each of our PROs. And I think one of the things that we can and should do is when we're presenting PROs to the neurologist, we should present them in a context. That is, just giving somebody a T-score isn't that helpful. But showing a T-score over a year, for example, and showing a percentual change, and showing on that same graphic, for example, what the MCD or MCID is for that individual measure, I think that will even further the incorporation of these measures into clinical practice and eventually makes them actionable items to the point where, if you have a change on a PRO, that could suggest that the patient is not responding as you would like to treatment, say hypothetically a medication that might prevent progression, and would prompt switch of a medication. These are, of course, are all very forward-thinking thoughts, but something that we can start working on right now.
Thank you very much, Daniel, for this answer. Let me just move to the next participant here. So, Per, you were running the MS Center in Copenhagen for a number of years. So you have a lot of experience. You were the first author of the paper describing the ideal role of a MS unit. So what should be, in your opinion, the model to ensure the uptake of PROMs in the different healthcare systems at the global level in that case?
Well, first of all, at a global level, we need to ensure that the different PROMs questionnaires are translated into the local languages. Of course, it's easy if you have a language spoken by in a large country, developed country, but it's much more difficult in less developed countries, or even in small countries like the Scandinavian countries. All people do not speak English. And we have found out that using PROMs in Denmark has been really a struggle. We have had campaigns targeting both patient and relatives, but also neurologists, because it's not easy to make neurologists feel to use them. And it's important that the PROMs are used actively in the daily clinical practice and not in a parallel activity. So it should be clear, it should be compatible with a smartphone, and we have also had our PhD students in every single MS patient organization in Denmark. So we have also included patients in selecting the PROMs that we are using, and by patient selections we are now having in the whole country the fatigue scale, the MSIS 29, the MS walking scale 12, a smoking, and a pre-visit questionnaire, so patient can tick what they want to talk with a neurologist on. So based on this now, more than 1,000 patients in the 3 big clinics have now signed up for using PROMs. And of course, they have access to the patient charts where the PROMs are registered, and it's also transmitted to the Danish MS registry. And they can look at a curve where you can see previous registration of PROMs to look at the development. So I think that within a year, we will have a much more larger proportion of the Danish MS patients using PROMs in daily clinical practice.
That's very good. Let me just clarify. So your PROMs are incorporated automatically within the electronic health system, or is that the case?
We have a common registration in all clinics, and they are a part of this now.
Okay.
And patients have been much more eager to introduce PROMs than neurologists, I have to say. Right. So we have the patients pushing for using PROMs in the Danish clinical practice. That's very important.
Okay. Thank you very much, Pierre. So I have the same question for Helga and Angela. On the side of patients, of course, what would be the cultural, socioeconomic factors acting as barriers to implementation, in your opinion?
I must agree with Professor Sørensen that the translatability of a PROM, and we need to ensure that the same information is captured regardless of the language that it's being translated into. The other thing is that when we consider that it needs to be a global approach, we must consider that the less developed countries where people have less access to how can I say, the internet or digital devices, capturing that information can be quite scary and intimidating. So we need to be mindful of that. And there are cultural differences as well, where people don't want to participate in something like this because they are suspicious of where that information is going to go, where it's going to be used. So that would probably be my contribution as the biggest constraints to and barriers that we could encounter.
Thank you.
And I would agree with what Helga just said, but also add access to smartphones and devices, reliable electricity, wireless data plans, and not just in less developed countries, but also in countries that are experiencing the outcomes and the effects of climate change, where there are more things happening, wildfires, more floods, more severe storms happening that could take down structures that are in place. So if there is an infrastructure even in place, making sure that that's secure enough to be able to translate the data.
Thank you. Thank you very much indeed. This is the last question for the two of you. Are those armchairs comfortable enough? Yeah? Sorry. So which are the requirements for the use of digital monitoring systems? How far are we from implementation in your perspective? Valerie and Paul.
So when you talk about digital monitoring systems, we need to be specific because we need to split out whether we're talking about PROs that are put on digital devices and deployed as apps, or whether we're talking about Fitbits and other devices. So I think for the first part, I will say on a global level, there's a lot to be done in consolidating what we have as tools that are accessible to people with MS, and that speak to clinic systems. I don't think we have anything that's robustly organized. We have providers that offer apps, but it's not yet at the point where things are synced more holistically for the field. For the digital device assessment, so for wearable sensors, I think there are a couple of providers, MS Copilot, and I think there's another one that have specific outcomes that are assessed using a wearable. There's still a lot more to get those adopted more widely by all stakeholders as acceptable evidence that could be used in a clinical trial setting, but also, I guess, in the clinical practice setting as well.
Yeah, I agree with that. And I think another problem is that we're all trying to validate a device for one specific symptom and not the myriad of symptoms. No patient ever has just one symptom. So joining all of these together, potentially on a platform like Bridge, I don't know if people are aware of what Bridge is. It's a platform that launches at UCSF from the medical record specifically and provides all the information relevant to the disease process of that person, and then provides specific input for the clinician that is actionable, and it can integrate patient-generated data perhaps. And so one thing we could do is, with the PROs, once we know that something's important to the patient, select from a suite and then go and measure with qualitative, objective measures using digital tools.